The treatment landscape in the UK is actually very straightforward because currently we only have one licensed and approved BTK inhibitor for second-line treatment, which is ibrutinib. There are as yet no head-to-head comparisons between BTK inhibitors in a randomized setting. So in order to choose between them, we really have to pick between single-arm phase 2 studies. And I think one thing that everyone agrees on when it comes to BTK inhibitors is they do have different side effect and toxicity profiles. So if you had the option of choosing between a covalent BTK inhibitor as second line, I would suggest currently the treatment choice comes down largely to what's available and to the toxicity profile. And so, for example, we're fully aware that ibrutinib has a association with cardiac toxicity, particularly arrhythmias such as atrial fibrillation in about 7% of patients. We know that the toxicity profile of the other BTK inhibitors is slightly different to that, so you may pick and choose based on the patient's comorbidities and the likely toxicity they might get. We also have non-covalent BTK inhibitors on the horizon, and there is a randomized study in progress, which is likely to report in the next year or 18 months, comparing pirtobrutinib with covalent BTK inhibitors. That might change our treatment choice, but currently I would suggest that the non-covalent BTK inhibitors, because they've shown good activity in patients who've had previous covalent BTK inhibitors, I would say the current place for these drugs is after previous BTK inhibitor treatment.